Hello everyone. Welcome to our Surgical Click series, Season 2. My name is Dr. Mufarraj Al-Hajri. I'm Senior Registrar from Amiri Hospital. And today we have thyroid malignancy from a special guest from the United States, Dr. Tanaz Bagwala. She's Assistant Professor of Surgery from University of Tennessee. She did her endocrine fellowship in Chicago, and she did her surgical residency in Miami University. For today's session, if you have any question, you can put it in the Q&A. And if you want to register for the next series, you can find the link in the chat. Hello, Dr. Tanaz, and welcome to our series.
Hi, everyone. Thank you so much for having me. It's such a pleasure to be here to talk with you guys about thyroid malignancy. This lecture is especially dear to me because of one of my mentors who is at your institution, Dr. Salman Al-Safran. So thank you again for having me, and I'll go ahead and get started. I have no disclosures. The majority of my talk about thyroid cancer will be from the current ATA guidelines, and I have several links to those within the presentation, as well as some imaging I've been able to find. So if you have any questions about where those are from, I'm happy to share that with you after the talk. So we have a lengthy list of objectives here, and I'll try my best to get through all of it. The primary focus will be on thyroid cancer. I'll just start off with a little bit of background about the thyroid gland. So a number of different diseases, most commonly that we're going to encounter, are things like thyroid nodules, thyroid cancer, Hashimoto's thyroiditis, hyperthyroidism for various reasons, and goiters. A little bit about the pathophysiology, and I'll touch very briefly on this. Of course, the thyroid has two types of hormone-producing cells. So the follicular cells that produce, store, and release our thyroid hormones, and then the parafollicular C cells that secrete calcitonin, which will become more important when we talk about some of the specific thyroid cancers. So the role of the follicular cells is to capture iodine from the circulation, concentrate it, oxidize it. This process occurs in the apical membranes of the follicular cells. And the tyrosine residues of thyroglobulin are iodinated, forming monoiodotyrosine and diiodotyrosine, which then couple to form our T3 and T4 that we test for on our routine lab work. So a negative feedback mechanism works through TSH, and when stimulated, release T3 and T4 into our circulation. So TSH is the chief regulator of thyroid hormone. It stimulates the follicular cells, like I said, to increase production and the release of our thyroid hormones into circulation. And this is stimulated by thyrotropin-releasing hormone, which is secreted by the hypothalamus. And it has that negative feedback loop, like a lot of our hormone processes. The parafollicular C cells, on the other hand, they stimulate and secrete calcitonin by high serum calcium levels. They inhibit osteoclast activity, which then decreases calcium levels. The thyroid nodule is probably the most common entity that we encounter in endocrine surgery, and for various reasons. Some of the most, and this is one of the main ways that thyroid cancer is going to present, which is why it's important for us to talk about. So when you have a patient in your clinic that you're seeing with a nodule, you want to ask some focused questions that will help you determine whether or not this is a nodule that we should be suspicious for a cancer. So certainly their age, Thyroid cancer is predominantly in women. Size, the rate of growth, whether they have any family members who have had thyroid cancer, and any radiation exposure to the neck. And then, of course, on your physical exam, you're going to look for any swelling within the lymph node basins along the lateral aspect of the neck, and whether the thyroid nodule is soft, whether it's mobile or fixed. Some of those findings will help you determine whether or not this could potentially be a cancer. And then this illustration just shows, a classic image of a thyroid goiter. So the diagnostic workup for a thyroid nodule begins with hormone studies, namely TSH and T3 and T4. The thyroid ultrasound we often consider as an extension of our physical exam because you'll see how important it is in the workup. And then certainly an FNA. And this image just shows an ultrasound guided fine needle aspiration of a thyroid nodule. So the differential diagnosis is very, very wide. And again, we'll focus on the cancer, but just to touch on a few things, there can certainly be benign nodules or toxic nodules, which are secreting excess hormone. And then on the malignant side of things, we'll go into further depth about the differentiated thyroid cancers, Hürthle cell cancer, which is a little bit more rare, and then some of the other thyroid cancers that may look familiar to you as well. So like I said, the thyroid ultrasound is really an extension of our physical exam. It gives us a lot of information. This is a very classic picture of what we'll find on ultrasound, and it really nicely illustrates the anatomy. So the white lines that you see here, these are our cartilaginous rings of the trachea. Here you can see the strap muscles that are draping over the thyroid. This is a transverse cut of the gland. You can see your isthmus overlying the trachea, as well as the right thyroid lobe. And then there's this suspicious nodule that we've circled here that has microcalcifications, has some irregular borders. And then, of course, laterally, you have your carotid artery and your jugular vein. So the reason why ultrasound is important is because over time we've studied certain features that can be suspicious for thyroid cancer. And some of these may be very familiar to you. So certainly things like microcalcifications, irregular margins, whether the nodule is taller more than wider, if it's predominantly solid, if it's hypoechoic, if it has increased vascularity. And a lot of these features are signs of a cancer, really of any type, cancers with more vascularity or predominantly solid, they certainly warrant more investigation. And then this image very nicely just demonstrates some of those features. And our radiology colleagues, they use, at least predominantly in the US, they use the system called TIRADS, which then further stratifies the findings on your thyroid ultrasound for whether or not they could potentially be a malignancy. And I won't go through all of these points, but some of the things that we had mentioned, whether or not it is, the shape, the margin status, the composition, whether it's cystic or solid, all of these different features can increase or decrease your suspicion for a cancer. And then the TIRADS criteria also takes into account size. So if they're more benign appearing on imaging, but they meet a certain size threshold, that may also warrant a biopsy. Another feature that's important when working up thyroid cancer is certainly once you perform a biopsy, those results can also have a range of results that are important to us. So the Bethesda classification system was developed to help standardize the process for diagnosis and management of thyroid lesions by FNA. And here it's a cytology specimen that's being obtained on fine needle aspiration. And the range of results that we can get start off with a non-diagnostic or unsatisfactory result, which would then require another biopsy. But then you have Bethesda II, which would be benign. And then it works up to a Bethesda VI grading, which would be a cancer, where you can see at the bottom of this chart here, that would have, 97 to 99%, essentially, it's a cancer. But there is this gray area that I'll talk about a little bit more, where you have anywhere between 5 to 30% chance of a malignancy, and there's some other testing that we can do to further work those up. So the Bethesda 3 and 4 category, or indeterminate nodules, these may be a cancer. So Bethesda 3, a little bit lower, malignancy risk of 5 to 15%. Additional testing that can be done here includes mutational testings, where we have certain panels of markers that can signify that this nodule may be a cancer. BRAF is one of the most well studied, and BRAF alone, interestingly, has a very high specificity of 99% for being a malignancy. Other known tests that have been popularized, at least here in the US, include Afirma and ThyroSeq, which have, again, a range of sensitivities and specificities. The Bethesda 4 category, which is a follicular neoplasm or a Hürthle cell neoplasm, these have a slightly higher range of malignancy risk of 15 to 30%. And again, Bethesda 3 and 4 nodules, or indeterminate nodules, are ones that are able to have these mutational testings that can help the endocrinologist or the surgeon determine whether or not this patient requires a surgery or another biopsy. So I'll jump into thyroid malignancies, and these are the different cancers that I'll go over today. First, I'll talk about differentiated thyroid cancer, which the vast majority of thyroid cancer that you'll encounter will fall under this well-differentiated category. So papillary thyroid carcinoma is the #1 most common thyroid cancer that we see in the population. It arises from the follicular cells. Some of the key features that we'll see on pathology are things like papillary cells, calcifications, psammoma bodies, and nuclear grooves. Papillary thyroid cancer metastasizes most commonly through the lymphatic channels, and distant metastases are to the bones, lung, and liver. There are certain variants then within papillary carcinoma that tend to be more aggressive, and these include tall cell variants, columnar cell, and hobnail variants. And again, that BRAF mutation, which is often a marker of more aggressive disease, is present in about 80% of tall cell variants. Follicular carcinoma is another one of our differentiated thyroid cancers. It's the second most common type of thyroid cancer we encounter. Also arises from follicular cells. The FNA, it doesn't always help us diagnose a follicular carcinoma, because what we need to see is whether or not the cancer has broken through the capsule of the nodule. And that's really when we differentiate, that's really how we differentiate a follicular neoplasm from a follicular carcinoma. And a lobectomy is often indicated here in order to help us with that diagnosis, because then we're able to see the entire capsule. Follicular carcinoma, unlike papillary thyroid carcinoma, metastasizes hematogenously, and the most common distant metastatic sites are the bones and lungs. Hürthle cell is a bit more rare. It's considered a type of follicular cell carcinoma. it tends to be more aggressive. It's a little bit less sensitive to radioactive iodine, unfortunately. So these tumors tend to be a little bit more of a aggressive cancer for the patients. The findings that we see on pathology include things like increased mitochondria. The follicular cells have a polygonal shape, but they do fall under the differentiated thyroid cancer. So I've included it there. The next thing I'm going to talk about is the staging for thyroid cancer. And we use TNM and the AJCC staging systems. It's separate for, there are distinct staging system for differentiated thyroid cancer from medullary, which we'll talk about later. The importance of staging systems, of course, like for any cancer, is that it predicts survival. It's based on, the clinical staging is of course based on the patient's physical exam and imaging findings prior to surgery. And then the pathological staging is based on clinical staging, histology, and intraoperative findings. So I'll go into this in a little bit more detail. Preoperatively, of course, after you've done your history and physical, things that are important for assessing local regional disease include complete thyroid ultrasound that includes the lateral neck. This is important because differentiated thyroid cancer can involve the cervical lymph node basins in about 20 to 50% of patients. And in with respect to micrometastases, you can find differentiated thyroid cancer in greater than 90%. Usually ultrasound is enough to for preoperative assessment, but some features on physical exam or ultrasound may prompt you to perform additional testing. For example, if you have a visible nodule that's fixed, it's bulky, or if you have lymph nodes that have the same characteristics, if you're worried that the thyroid on physical exam has a substernal component, then a CT or an MRI would be very helpful in helping to assess the extent of the size of the goiter and whether or not there's any local regional invasion. If the patient presents with voice hoarseness, then a laryngoscopy would be very helpful in your workup. And this would help you because you may find that if the patient has vocal cord dysfunction, that would lead you to believe that this tumor has probably already invaded the recurrent laryngeal nerve on that side. And so you would definitely exercise extreme caution when you get to the other side. But it's important to have this information up front. The lateral neck compartments, I can go through this a little bit, just briefly, but more commonly we'll see lymph node metastasis in thyroid cancer to the central neck or level 6. But then beyond that, and the reason why we get our lateral neck ultrasound is to see whether or not any of these lateral lymph nodes have any metastatic disease. And that way you can address both the thyroid cancer and the lymph node disease at the same operation. This just goes into great detail about the TNM staging, and it actually becomes pretty clinically relevant in terms of what type of operation you're going to give them and how you will manage their thyroid cancer after surgery. We'll keep seeing this distinction between tumors less than 2 centimeters and tumors greater than 4 centimeters. So this T1 and T3 TNM criteria becomes increasingly important as we go on, and I'll mention those again. This just gives a nice visual depiction of what we're talking about. So the smaller size tumors, obviously have a lower TNM class distinction, whereas in T4A and T4B, you're starting to see this local invasion, which will impact your surgical planning. And this picture quite nicely depicts the lymph nodes that can be involved. So typically we would see central lymph nodes in level 6, but once you get into N1B, we're talking about that lymphatic drainage to the lateral neck along the inferior jugular vein. Now, the staging here is especially important. And one of the unique things about differentiated thyroid cancer is that age is a very, very important component, and it predicts survival. So you can see here that age less than 55, for those patients, no matter what size of their primary tumor within the thyroid is, no matter if they have lymph nodes or if they even have distant metastatic disease, you can only ever be stage 1 or 2. And these patients still have a generally excellent survival. Now, when you go into age greater than 55, the more kind of classic staging criteria that you see for some of your other cancers, it's a little bit more similar to that, where it takes into account, the lymph nodes are going to give you a higher staging, and certainly distant metastasis is going to put you in that highest category, and it impacts survival very dramatically. This again just summarizes a little bit specifically for differentiated thyroid cancer. Again, you can see where age makes a big difference. One of the characteristics that we'll talk about that become more important after surgery in terms of whether or not the patients require additional therapies is whether or not there's something called gross extrathyroidal extension, or whether the cancer has moved beyond the capsule of the thyroid. So there's always this question about how much surgery is too much and what surgery is indicated for the patient, but the ATA guidelines do give us some firm guidance on this question. So total thyroidectomy for differentiated thyroid cancers, for tumors that are greater than 4 centimeters, tumors where extrathyroidal extension is either seen on imaging, whether clinically metastatic nodes are present, like bulky lymphadenopathy or biopsy-proven lymphadenopathy, or distant metastases. In those patients, total thyroidectomy is indicated. We get into this gray area where there's a little bit of variability for tumors greater than 1 centimeter and less than 4 centimeters. So for patients who a lobectomy is indicated, these are typically the lower risk papillary and follicular cancers. Patients who don't have patients who don't have extrathyroidal extension, they don't have lymphadenopathy present, and they don't have distant metastatic disease, like we said. The reason why total thyroidectomy is beneficial sometimes in certain cases within this size criteria is whether the patient will need radioactive iodine, whether they'll need follow-up of their thyroglobulin, which is what we use for thyroid cancer surveillance. Those patients may benefit from a total thyroidectomy, and we'll talk about that a little bit more as well. So again, this sort of just reiterates some of the similar points, but for patients where a lobectomy is indicated, we're again talking about those that for sure less than 1 centimeter without extrathyroidal extension and no lymph nodes being positive, those patients can safely undergo thyroid lobectomy. And this is usually enough definitive treatment for small unifocal intrathyroidal cancers, patients who have not had prior radiation, patients who do not have familial thyroid cancer, or like we said, lymph nodes. So the treatment for differentiated thyroid cancers, first is surgery. Like we talked about, some of the criteria for lobectomy versus total thyroidectomy, whether or not that's performed. Certainly if total thyroidectomy is performed with central node dissection, if there's positive nodes present, or lateral neck dissection if there are positive nodes present in the lateral neck. So we don't routinely do any prophylactic central node dissections or lateral neck dissections, which will differentiate it from a different subset of thyroid cancer that we'll talk about later called medullary. A procedure that is called nodulectomy, where you're just coring out the thyroid nodule, is really contraindicated. We typically want to see the thyroid tumor within the thyroid tissue, because we have to, like I said, assess for some of those important features like capsular invasion, angio invasion, and you're not going to see any of that if you're just removing out, if you're just removing the nodule. After surgery, we suppress TSH by giving levothyroxine and plus or minus radioactive iodine. So who gets radioactive iodine? This is a very dense chart, but it gives a lot of really important information. Some of the things that we've already talked about, so hopefully it'll start sounding more and more familiar. But who's definitely getting radioactive iodine? Patients with tumors of any size that have gross extrathyroidal extension, patients with distant metastases. Who are the ones that are definitely not getting radioactive iodine? Are those tumors that are less than 1 centimeter in size, ones with typically unifocal disease. Tumors between 1 and 4 centimeters, again, we're in sort of that gray area where it's not routine, but if there are some aggressive features on pathology or certain historical risk factors for the patient, it may push our endocrinology colleagues to offer radioactive iodine. And then certainly there's that gray area where it can be considered, but it's not a hard yes. And those are the patients where the tumors are greater than 4 centimeters, but they may have other lower risk pathological features. If the extrathyroidal extension is microscopic, if they have central compartment lymph node metastases, there's some, but you've removed all of the tumor, there may be some argument for not giving radioactive iodine. In general, from what I've seen from our endocrinology colleagues, they tend to offer it for these cases. Now we'll shift gears and talk about medullary thyroid cancer, which is an entity of its own and has a lot of unique features. So these cancers arise from the parafollicular C cells, which, like we said, secrete calcitonin. They account for about 5 to 8% of all thyroid cancers, so they're pretty rare. They're aggressive but slow growing, and they have a worse prognosis compared to differentiated thyroid cancers. So their 10-year survival rates range from 61 to 76%. And distant metastatic sites are lung, liver, and bones primarily, and then in rare instances, the brain and skin can be affected. Medullary thyroid carcinoma, on pathology, they have round to oval nuclei, amyloid deposition, they stain positive for calcitonin. And then further studies with IHC analyses can be performed looking for calcitonin, chromogranin, CEA, and these will typically not stain for thyroglobulin, which are differentiated thyroid cancers would stain for thyroglobulin. Medullary carcinoma metastasizes early to lymph nodes. We talked about the distant mets being primarily to the liver, lungs, and bones. 80% occurs sporadically, and 20% have a RET proto-oncogene mutation associated with the MEN2 and familial medullary thyroid carcinoma syndromes, which we'll talk about. So the workup is very similar to our differentiated thyroid cancers, starting off with the thyroid ultrasound and FNAs to confirm the diagnosis, followed by calcitonin levels, CEA levels, dedicated thyroid and lateral neck ultrasound to look for lymph nodes. If the calcitonin is elevated greater than 500, the patients have a greater chance of having distant disease. And so we would want to investigate for that by doing CT, chest, abdomen to look for any distant metastases, for example, in the liver. And they have a higher chance of having local lymph node metastases to the lateral neck. Patients certainly who have sporadic medullary thyroid cancer, or even if when we know that they have a familial genetic mutation, they should undergo counseling in order to detect what specific RET mutation they may have, because that will influence what other potential cancers that they might develop down the road. The RET proto-oncogene is associated with our MEN2A and MEN2B. We have to remember to screen for FIO because we don't want to take the patient to the operating room for their medullary thyroid cancer until we've determined whether or not they have a pheochromocytoma, because our anesthesiology colleagues will not be happy with us, and neither will the patient. We want to screen for hyperparathyroidism and genetic counseling, especially if they have family members. We want to be able to make sure that they're all getting the appropriate care. This flow chart is, I obtained this from the ATA guidelines specifically for medullary, and it just goes through a lot of the same things that we talked about. The initial diagnostic workup, including ultrasound, labs, detecting DNA analysis for any RET mutations. If the patient is RET negative, we go down this pathway. We check calcitonin. If it's elevated, we want to make sure we don't have distant metastatic disease. If it's less, then we want to do a total thyroidectomy with or without cervical lymph nodes, depending on their ultrasound findings and calcitonin levels. I'll talk a little bit more about management of distant disease later. If they are RET positive, we want to evaluate for pheochromocytoma. We want to evaluate for primary hyperparathyroidism, and then address surgery based on what those findings are. So a little bit more about medullary. Typically, we offer these patients total thyroidectomy and central lymph node dissection because we know that they metastasize early to their central neck. And so central lymph nodes means level 6. This is for localized disease. This is going to be plus or minus ipsilateral modified radical neck dissection, which we're typically only doing if we find biopsy proven disease there, or suspicious lymph nodes on ultrasound, or bulky lymphadenopathy. There's unfortunately no role for radioactive iodine, so we don't have that in our arsenal to treat these patients. Just some general rules, not rules, but just some general guide of sort of the classic scenarios for these patients. Of course, every patient's different, and has an individual, consultation with you regarding their care. But in general, if the disease is confined to the thyroid, we offer total thyroidectomy and central lymph node dissection. For patients with no neck metastases and no distant metastases, then modified radical neck dissection can be considered if there are elevated serum calcitonin levels. And at the time that these guidelines were created by the ATA, there was really no consensus about this point. So this may be sort of a surgeon dependent or multidisciplinary, require that kind of collaboration with your endocrinologist. There was consensus regarding disease confined to the neck and cervical lymph nodes being present. Those patients would get total thyroidectomy, central node dissection, and modified radical neck dissection. For those patients with disease in the ipsilateral neck, but negative in the contralateral neck, you can consider a contralateral modified radical neck dissection if you have elevated calcitonin levels. So you can see is very different surgical management and surgical approach to compared to differentiated thyroid cancer. The MEN2 patients, when adults are found to have a RET proto-oncogene and are found to have MEN2, you can surveil them with calcitonin and perform total thyroidectomy once the calcitonin is elevated. We offer them central node dissection as well, and modified radical neck dissection if they are node positive or PET avid or other suspicious features for involvement of the lateral neck. For kids, it's a bit different. So MEN2A, we perform prophylactic total thyroidectomy without central node dissection by age 5. We know that the MEN2B patients tend to have more aggressive form of medullary thyroid cancer that presents earlier in these patients. And so we offer them prophylactic total thyroidectomy by age 1. MEN2A, of course, hyperparathyroidism, medullary thyroid cancer, and pheochromocytoma. MEN2B, just to recap, again, medullary thyroid cancer, pheochromocytoma, and then they can have these mucosal neuromas and marfanoid features. Familial medullary thyroid cancer is considered to be a variant of MEN2A, and there are certain criteria to be able to be given this diagnosis, and it depends a lot about family history. So just briefly, families that have at least two generations of at least 2, but less than 10, or subjects with the RET positive germline mutations, families with less than or equal to 2 members in a single generation who have the RET germline mutations, or single individuals that are found to have a RET germline mutation. The distant metastatic sites for medullary thyroid cancers, there's a few different approaches to their management. So for patients with locally advanced disease, it's really aimed at getting control of local invasion. We can offer them external beam radiation. We can offer them systemic therapies. Typically, it's non-surgical because we're really just trying to palliate these patients and, not have them have quality of life issues in terms of whether there's invasion of their aerodigestive tract or local invasion causing pain to nearby areas. For metastatic disease, we're less aggressive about their neck operation because we know it's already spread, unfortunately, and the approach is aimed at palliation. For brain metastases, if localized, surgery is still an option. And if not, then radiation therapy comes into play. Medullary thyroid cancer can metastasize to the skin rarely. And if localized, surgery is an option. If not, then radiation and ethanol injections can be performed. And for bone metastases, there's a range of options here, including surgery, thermoablations, radiation, bisphosphonates, and then systemic therapies, which we'll talk about. Isolated liver metastases, the approach is aimed at surgical resection if the patient is a candidate for surgery and the tumor location is amenable to surgery. If the patients have significant disease and are having symptoms like diarrhea, compressive liver metastases, then we're focusing on more palliation, debulking, radiation, and systemic therapies in the form of tyrosine kinase inhibitors. This flow sheet is, again, this is just focusing on those patients with RET germline mutations, and it goes into a lot of the things that we've talked about already. And it's just a note here about, again, MEN2A, we're trying to, our goal is to perform total thyroidectomy before age 5. The MEN2B, it's before first year of life. In adults, it's a different approach. If they have a normal serum calcitonin, we can perform annual testing and revisit surgery once the calcitonin starts to rise. If they have elevated serum calcitonin, we want to, of course, exclude FIO, and then we offer them that total thyroidectomy and central node dissection. Anaplastic carcinoma is a very, very different entity. Now we're talking about poorly differentiated thyroid cancer, and they will present often already with symptoms, with a large mass. Their history may say that it's progressed rapidly over the past few weeks to months. Unique features for them, again, we're talking about poorly or undifferentiated cell histology. This is, it's very rare. Fortunately, it's 1 to 2% of thyroid cancers. It's very often rarely caught in time to be resectable. The patients, like I said, will present with a rapidly expanding mass within the neck. It's often already invaded local structures and can cause airway compromise. So these are just some images of an anaplastic thyroid cancer, and you can see it's very heterogeneous, it's large, it's causing this bulky effect, pushing the trachea off midline, and they'll often present with symptoms of this. The treatment goals are really aimed at local control of the disease and diagnosis. So it's really more of a surgical biopsy and debulking procedure in order to get airway control. There are clinical trials, and that's often the preferred method because these tumors are very rare. Combined radiation and chemo, and really just providing with the best supportive care that we can, because we know that these patients, have a very poor survival and have a rapidly progressive course of their disease. Thyroid lymphoma also can present with a rapidly enlarging neck mass. They classically, the sign for them is this sort of donut shaped, diffusely enlarged thyroid. It's diagnosed on FNA, and you see the monoclonal lymphocytes that you see in other lymphomas. And the treatment is similar to other lymphomas with chemotherapy. And typically, surgical debulking is not beneficial. The rare exception may be if you have a localized focal tumor within one lobe, but that's not often the case. Thyroid cancer, the thyroid can actually also be the site of distant metastases for other cancers. The majority of which would be 25 to 50% being renal cell carcinoma. For these patients, resection is indicated in select patients if the disease is localized within the thyroid, being one of the main considerations. Often they're being treated for disease metastases elsewhere. And so systemic therapies then are what's recommended. And you can see, just like in renal cell carcinoma pathology, that they'll have these nests of clear cells. Now we'll go into some issues that are relevant from a surgical standpoint, and I'll go into some of the anatomy. So the thyroid gland, of course, has the two right and left thyroid lobes connected in the center by the isthmus. The embryologic origin is the foramen cecum, which then migrates ventrally to the hyoid bone, and this can be the site of thyroglossal duct cysts. The arterial supply is the superior thyroid artery via the external carotid, and the inferior thyroid artery via the thyrocervical trunk. And then the venous drainage is through superior, middle, and inferior thyroid veins. Just briefly, the steps of the operation, and this comes up for us in our oral boards, being able to sort of summarize the key steps. From a practical standpoint, the positioning is very important to the operation. And typically we'll have, the patient will be supine, they'll have a shoulder roll, and we'll want a little bit of neck extension, which will really help bring that thyroid out into our surgical field. We start with an anterior collar incision for the traditional open thyroidectomy. We create subplatysmal flaps, and the boundaries of our subplatysmal flaps are laterally the SCMs, and then superiorly being the cricoid notch, inferiorly being the sternal notch. After we have this exposure, then we divide the strap muscles in an avascular plane at the midline. We expose the lateral thyroid. Typically, we'll start with the side that has the disease pathology. You identify, ligate, and divide the middle thyroid vein, which allows you to rotate the thyroid medially. Then we identify, ligate, and divide the superior poles. And once you're able to bring that down, that's when our recurrent laryngeal nerve comes into view at the TE groove, and we want to identify and preserve that. After this, then we complete the operation by identifying, ligating, and dividing the inferior thyroid vessels. Then typically we should be able to rotate the thyroid in an avascular plane off of the trachea and out of the surgical field. This image just shows the superior thyroid lobe and the significance of, once you bring that down, you're able to see that recurrent laryngeal nerve in the tracheo-esophageal groove. And this shows more of a sort of realistic view in the OR, where we've taken down the superior pole here, we've taken down the middle thyroid vein, which has allowed us to medially rotate our thyroid off of the trachea and identify our recurrent laryngeal nerve. Now, we'll talk a lot more about the recurrent laryngeal nerve, because this is the most dreaded complication of the surgery that we do. The reason why it's important is it supplies the intrinsic muscles of our larynx, all of the muscles except the cricothyroid. The anatomy is a little bit different, which also affects our surgical approach. So you can see that the left laryngeal nerve has a straighter course along the trachea, whereas the right is a little bit trickier. It comes in at an angle, which is important to know when we're trying to identify it. Typically, the board answer for where the recurrent laryngeal nerve is in the tracheo-esophageal groove. The superior laryngeal nerve, it's not one that we will often see, but it does have important functions. So the internal or sensory branch innervates the mucosa of the larynx, and the external branch has motor function and innervates that cricothyroid muscle. And an injury to this nerve will cause a change in pitch, to your voice. So for our opera singers, this is very important. The recurrent laryngeal nerve injury to that will cause a voice hoarseness, voice fatigue, difficulty swallowing, particularly thin liquids. So you can imagine it can be very debilitating to patients who have this injury. They can be at higher risk for aspiration, which is important. And some of the ways that we will, if you suspect a nerve injury during surgery, if you have recurrent laryngeal nerve monitoring, that can help you. You may identify loss in signal, and that will clue you into potentially having a nerve injury. Other things are you could certainly stretch the nerve, and that may cause similar symptoms, but is often temporary. If you do not believe that you have a recurrent laryngeal nerve injury, but after surgery, the patient is having some of these issues, then a laryngoscopy is indicated to ensure that they have good cord function. If the patient has a nerve injury, things that can help after surgery are, first, we'll perform a laryngoscopy first, swallow studies to determine the extent of aspiration that they have. Speech pathology works well with our patients, helping coordinate how they swallow, and vocal cord injections can be helpful to bring that vocal cord into place, but it doesn't always, it doesn't regain the function. It's been studied whether or not we should, in surgery, identify the nerve and preserve it, or whether we should try and avoid it altogether and hopefully not get anywhere near it. So there's two schools of thought. In studies that have been done, it's been demonstrated that the rates are lower when the nerve is routinely visualized in surgery and preserved. The risk that we tell patients it's in about 1% of patients who have had no prior neck operation. There is this risk of recurrent laryngeal nerve injury. The risk can be higher in patients with who've had prior neck operations. And for those patients, I'll routinely get, if they've had, when I mean prior neck surgery, I mean that they've had surgery to the thyroid or parathyroids before, or they've had other spinal surgery where they may have encountered the nerve. If there's anything like that that's happened in their previous history, then I would get a preoperative laryngoscopy. So some of the other complications of thyroid surgery, permanent hypoparathyroidism is fortunately very low risk. It's about 1% of patients. This can have a permanent condition of hypoparathyroidism. These patients will present with classic symptoms of low calcium, like numbness and tingling around the mouth and fingertips. This can progress to muscle cramps and tetany if not treated, and requires often lifelong calcium supplementation if it's a permanent injury to all 4 parathyroid glands, which is fortunately very rare. It can occur transiently in up to 80% of patients. And so patients undergoing total thyroidectomy, for me, routinely, I'll check calcium postoperatively and add calcium if I do see any signs that they may have some transient or short-lived low calcium. Risks of bleeding and infection, those are even lower for this operation. So bleeding requiring a repeat trip to the OR to be addressed is less than 1%. The classic scenario that you might encounter for your boards, or even important to know clinically, is the patient who's had previous neck surgery, and now you're getting a call from the nurse that the patient's having shortness of breath or desaturation. You want to go up and see them immediately and determine if they're having airway compromise from a compressive hematoma. And often what we'll do is open the incision really quick at the bedside, at least the superficial skin layer, and try and relieve or decompress that hematoma. And then, after you've done that, or while you're doing that, you have your anesthesia colleagues come and meet you. You get the OR ready to go back and address the bleeding. But bleeding requiring reoperation is very low in less than 1% of patients. Typically, you don't really find a bleeding vessel. You might find some oozing, but you don't typically find like one, pumping vessel. Surgical site infection also are very low in less than 1%. Oftentimes, we don't give patients who are not immunocompromised perioperative antibiotics, but that might be surgeon preference. It's been studied whether what the complication rates are for individuals who are doing neck operations more routinely. And it's been found that overall complication rates for high volume surgeons, high volume being defined by guidelines to be about 100 cases a year. Complication rates for lobectomies, we're talking overall complication rates, including all of the things we've discussed, 7%, and total thyroidectomy being 14%. And I may be quoting the numbers incorrectly, but if my memory is correct, I believe for low volume, the lobectomy rates start approaching now 10, 11, 12%, and total thyroidectomy start getting overall complication rates of about 20%. And again, this is from our ATA guidelines. Now, after surgery, what is our goal? So for thyroid cancer, we want the patient to be disease-free. So how we define what disease-free is there's no tumor present clinically, there's no tumor present on imaging by radioactive iodine or ultrasound imaging, and they have a low serum thyroglobulin during TSH suppression of less than 0.2. Some of the adjuvant therapies now we're shifting back to differentiated thyroid cancer. So medullary was a different entity. External beam radiation is still controversial. Routinely, it's not performed for well-differentiated thyroid cancers, but it can be considered for patients who need palliation for local regional recurrences. Adjuvant chemotherapy, there's no routine adjuvant chemotherapy that we're giving for these patients. Surveillance is very important for our differentiated thyroid cancers. TSH and thyroglobulin measurement are some of the mainstays of our routine surveillance. So if the patient has had prior radioactive iodine, if they are low risk by ATA standards, meaning low risk tumor, we measure thyroglobulin and thyroglobulin antibodies every 6 to 12 months, and then we space that out every 1 to 2 years. If they are high risk, every 6 to 12 months for several years, and then TSH is measured annually. If they have not had radioactive iodine, it's really, there's really no set threshold. We're unsure what a goal threshold should be for these patients, but a rising thyroglobulin may alert you that the patient may have, local recurrence or metastases and would warrant additional workup. Thyroid cancer surveillance, like I said, involves TSH suppression. And this just talks about what the targets are. So you may not need to suppress the TSH as much for lower risk tumors or for patients with certain health problems. Cervical ultrasound is also an integral part of surveillance. So ultrasound again at 6 to 12 months, and then at longer intervals depending on their risk of recurrence. A positive result would change management typically in a few certain scenarios. So if you see suspicious lymph nodes that are greater or equal to 8 to 10 millimeters, it's generally recommended that they should undergo a biopsy with thyroglobulin measurement, and the cutoff for thyroglobulin is greater than 10. Suspicious lymph nodes less than this size cutoff, you could potentially follow them and perform FNA if they enlarge or if there's other concerning features. For patients with low risk differentiated thyroid cancers who have undergone radioactive iodine, have normal thyroid ultrasounds, and low thyroglobulin levels on hormone replacement, they can undergo surveillance by clinical exams and serial thyroglobulin measurements. For FDG PET, potentially a role for them in the high-risk differentiated thyroid cancer category if their thyroglobulin levels are rising and they have no findings on radioactive iodine. So you're in that scenario where they have a higher risk tumor, you're not picking up anything on an uptake scan. Potentially there may be a role there for PET scanning. For patients with poorly differentiated thyroid cancer or invasive Hürthle cell disease or metastatic disease, then PET can be performed for initial staging workup. This repeats the same thing. CT or MRI can be performed when we cannot fully image the extent of nodal disease, or if there is recurrence and we can't appreciate the extent of that, to look for invasion of nearby structures. If you have a high thyroglobulin but a negative cervical ultrasound, and to evaluate for distant metastases. I'll talk a little bit about transoral thyroidectomy. You have an expert in transoral thyroidectomy at your institution, so this may not be news for you. But this novel approach, we've had excellent outcomes in our patients. We typically call this scarless thyroid surgery, or the true scarless thyroid surgery, because the patients have no outward incisions. I'll show you shortly their incisions along the inner mucosa of the mouth. There was a wonderful study, a multi-institutional study looking at the indications and eligibility for this approach. And they found that over half of the patients met general criteria for this approach. And so hopefully if the patients if the patients come interested and they are good candidates for surgery, this just shares with other institutions out there that there may be more patients than we think that are eligible for this approach. Just generally, indeterminate thyroid nodules, primary hyperparathyroidism, benign thyroid conditions, and thyroid cancers less than 2 centimeters in size. You'll notice here, I don't know if you can read the citation here, Dr. Salman Al-Safran is one of the leading authors on this paper. So these candidates for these patients, from a surgical standpoint, ones that have not had prior neck operation or radiation, ones who are not localized for primary hyperparathyroidism, it makes it a bit more challenging. If you need to do central or lateral neck dissections, thyroid cancers greater than 2 centimeters, patients who have multiple medical comorbidities, patients who have more than one of these contraindications that are on this list. Substernal component is hard to access transorally. And thyroid lobes greater than 10 centimeters, benign nodules greater than 6 centimeters. It makes it challenging. So this is where we would place our incisions. 3 small incisions along the inner mucosa. We then place our trocars. And then from there, it's very similar to our typical laparoscopic principles, where we develop our exposure planes, creating those subplatysmal flaps, and then taking down doing our lateral dissection of the thyroid, taking down our superior pole, identifying the recurrent laryngeal nerve, and then removing it off of the thyroid and off of the trachea and removing it through the mouth. And this is a nice image where you can see we are looking at the anatomy upside down, which takes a little bit of adjustment. So this is the trachea. This is the right thyroid lobe that's being medially rotated off of the trachea. And we're looking at the recurrent laryngeal nerve. And I believe this might be, not sure what this is up here. Maybe it's a parathyroid. This is what the patient is left with. And the outcomes, there's been a great deal of study of this by the surgeon who really popularized this approach, Dr. Anuwang, and he has, at the time of my experience with him, they were, well over 1,000 cases for these patients. And the results were very similar to open approach. So about 6% had transient recurrent laryngeal nerve injury, which recovered. About 11% had short-lived hypoparathyroidism. There were 0 recurrent laryngeal nerve injuries, 0 instances of permanent hypoparathyroidism. One unique aspect is sometimes they'll have a little bit of numbness at the midline of the lower lip, but the procedure has been adjusted to help address that. And I would imagine that the rates are even lower if they studied it with more recent data. One finding that was clinically significant is that the OR time was significantly longer for the transoral approach. There was no difference, however, in blood loss and no difference in complication rates. This just shows a demonstration of the, not a demonstration, but just illustration of the comparison between conventional open thyroidectomy and transoral. And you can see that there's really no significant difference if you're looking at these p-values in a lot of these different things like blood loss, transient nerve injury, permanent nerve injury, low calcium. We're not seeing any big changes other than OR time. I just was going to touch on some of the recent guidance that the American Thyroid Association put out regarding COVID-19. We definitely get a lot of concerns from patients and a lot of calls to our clinic about how they can proceed with their care. And fortunately, we have some answers that we can give them based on the American Thyroid Association's guidelines. So if patients coming in asking if it's safe to delay a biopsy of a thyroid nodule, generally the thinking is that it's probably safe to delay a biopsy unless your physician feels strongly that an urgent biopsy is necessary. And the rationale behind this is, as we talked previously, most thyroid nodules are benign. The exception to this is, of course, if your physician was concerned about suspicious features or aggressive features on imaging or clinical exam that may, push the physician to want a more urgent biopsy. But in general, it sounds like it's probably safe. Is it safe to delay thyroid surgery because of the COVID-19 pandemic? So while thyroid cancer is treated initially with surgery, the chance of thyroid cancer worsening if surgery is delayed by just a few months is extremely low. And this is particularly for slow-growing tumors like differentiated thyroid cancers. And it's probably also true for small lymph node metastases. Generally, we recommend against delaying thyroid surgery for symptomatic disease, particularly symptoms due to size, airway or swallowing symptoms, evidence of invasion on imaging or clinically, and then certainly for any anaplastic or medullary thyroid cancers. And then I believe this is the last question I have on here is, are people with thyroid cancer at greater risk for COVID-19 because they are immunocompromised, which is a really good question. So fortunately, unlike other cancer types, the vast majority of thyroid cancer patients are not receiving any type of chemotherapy. And the medications that we give patients for thyroid cancer do not affect their general immunity and ability to fight off infection. So a diagnosis of thyroid cancer and receiving thyroid cancer hormonal medication is not a known risk factor at this time for getting COVID-19 or being at higher risk of severe illness. And patients receiving chemotherapy are at certainly higher risk for severe illnesses during COVID-19, but generally thyroid cancer patients don't fall into that category. Now I have a few prepared questions, so we could move on to that.
Yes, doctor, we can start the first question. Can you read it for us, please?
Oh, sure. Okay, so a 29-year-old female presents with swelling in the left neck. Physical exam shows a palpable 2-centimeter left thyroid nodule. A thyroid ultrasound demonstrates a 2-centimeter thyroid nodule within the left thyroid lobe, and no lymphadenopathy in the bilateral neck. A biopsy shows groups of cells with round to oval nuclei, amyloid deposition, and staining that's immunopositive for calcitonin in all tumor cells. She has no known family history of thyroid cancer, and she has normal serum metanephrines. What surgery would you offer this patient?
We'll give them a few 30 seconds to answer the questions.
Okay.
Just a few seconds.
Sure. Let's see. A left thyroid lobectomy. Okay. All right. We'll definitely talk.
Yeah.
We'll definitely talk about this some more. So I'll move on to my next slide. Okay. So what I was on pathology, I was describing a medullary thyroid cancer. So the medullary thyroid cancer, remember the buzzword here is that they're positive for calcitonin. You know, the other features, sure, amyloid deposition and all this, but really, as soon as you hear the word calcitonin, you can start thinking that we're talking about a medullary thyroid cancer. And then the other hint was that I did give the fact that they had normal serum metanephrines, which in a medullary thyroid cancer patient, before you take them to surgery, we just want to make sure that they don't have one of those Rett syndromes. So that should be the first clue that we're dealing with medullary thyroid cancer. So then once we know that we're not dealing with those less aggressive differentiated thyroid cancers, who may be, you know, a lobectomy may be indicated, you know, for a 2 centimeter tumor without lymph nodes present. But in this situation, we have a higher chance of early lymph node metastases, specifically to the central neck. So this patient should get a total thyroidectomy and a prophylactic central node dissection. And just a reminder that the modified radical neck dissection is really for the clinically positive or biopsy positive nodes. The other point I don't have in here is the elevated level of calcitonin may push, you know, those conversations between the endocrinologist and the surgeon to see whether a prophylactic lateral neck dissection is indicated. But generally, the way this case was presented, I believe a total thyroidectomy and prophylactic central lymph node dissection is what's needed. And then always consider genetic counseling for the patients who have a new diagnosis of medullary thyroid cancer. And I can go on to the next question. I'll go ahead and read it for you guys. So a 47-year-old female presents to your clinic for a postoperative visit. On pathology, she was found to have a 4-centimeter papillary thyroid carcinoma invading the thyroid capsule and strap muscles. She also has metastases to the bone. What would be her clinical stage per current guidelines?
So we'll give them 30 seconds to answer the question. And then we'll share the answer and we'll see. Last few seconds, everyone.
Okay, so we'll talk a little bit about this one. So the unique thing about differentiated thyroid cancer is that age plays a big part in the staging. So the patient's age at presentation predicts their survival for well-differentiated thyroid cancers. And remember, there was that age greater than or less than 55. So if patients are less than 55, they can only be staged 1 or 2, no matter if they have distant metastases, which is just very unique thing about thyroid cancer staging. So although this particular patient has advanced disease, she still falls under a stage 2 with a fortunately really excellent prognosis, given that her age is less than 55. And when we're done, I can go back to that table, you know, and just illustrate that again. I'll go to the next question. Which of the following types of thyroid cancer would not be sensitive to radioactive iodine?
So we'll wait for 30 seconds, same routine. So just a few seconds more.
Oh, great. So this is an interesting question. So majority of you answered perfectly. So anaplastic thyroid cancer is a poorly or undifferentiated thyroid cancer. It does not respond to radioactive iodine. Unfortunately, it's that rare and aggressive form of malignancy that has a very poor prognosis compared to the other tumor types. Really, the surgery is aimed, because they often present at later stages. Surgery and radiation aimed at palliation or airway control are typically the first steps, because they present so aggressively early on. It's interesting that some of you also answered the Hürthle cell type, because there is a lot of literature out there asking whether or not these tumors do respond well to radioactive iodine. This is that variant of follicular cell carcinoma. But in general, at least what I've seen in my experience is we are generally treating them with radioactive iodine, and they often can be very aggressive, have very aggressive features on their pathology. And generally, I've seen us offer a radioactive iodine for these, but it was interesting that a great many of you had answered that as well. Well, I just wanted to thank you all so much for having me, especially Salman. I really appreciate it. Salman has been my mentor throughout my training, and so it's funny for me to be coming back and instructing, but I am very, very grateful for the opportunity. And I know we're almost out of time. I'll just take a quick look at your...
Yeah, we just have a few questions that we can answer, a couple of them.
Sure.
There's one question where you will categorize the non-invasive follicular thyroid neoplasm with papillary-like nuclear features.
Where you will categorize. Oh, so these often NIFP is definitely something, a pathologic diagnosis that's been popularized probably in the last within 5 to 10 years. And it's generally like a lesser aggressive form. It's a variant of papillary thyroid cancer that takes on less, aggressive nature within that. I did see this question about when to perform a nodulectomy. I really can't tell you a scenario where I would think that a nodulectomy would be indicated, because as you can see, a lot of these features that determine the aggressive nature of a tumor, you have to look at the surrounding normal thyroid tissue. For example, in follicular cancer, you really want to see that capsule to see if there's invasion. The same thing with Hürthle cell, we look at capsular invasion, we look at angioinvasion. So oftentimes we don't, not oftentimes, I mean, we just don't do nodulectomies for cancers. We don't even do it for benign disease. The other thing I wanted to mention is that from a technical or surgical standpoint, a nodulectomy can be very challenging because the thyroid is such a vascular organ. To remove a piece of the thyroid without performing those series of steps that we talked about, where you obtain the control of the vascular pedicles, you're just going to have a lot of oozing and bleeding from the tissue that is going to be quite challenging to address. Whereas the lobectomy, if you're looking for a diagnosis of a nodule, that is going to really address the issue of diagnosis, and then also prevent any of that intraoperative challenging technical aspect of bleeding. Somebody else wrote that they always give calcium supplement after total thyroidectomy. I think that that's perfectly reasonable. I've had a lot of my mentors in training who have given calcium supplement routinely or make it an as needed recommendation in their prescriptions. If I'm operating on an enlarged thyroid, or if it was a challenging case or a big goiter, particularly like Graves' disease, where or just those benign large goiters, I would say it's probably a higher risk of devascularizing or stunning the parathyroids. And so I would just go ahead and start them on calcium. In my practice, I check the calcium and PTH levels after surgery, usually in recovery. And I check them again in the morning because I'll typically keep the total thyroidectomies overnight. And then, you know, whether or not you're starting calcium immediately or you start it at discharge, depending on what your labs show, I think either way is perfectly reasonable.
All right, perfect. I guess that's it. Thank you so much, Dr. Tanas, for this amazing lecture. We are really honored and pleased to have you with us. And we hope to see you in the future and to visit us in Kuwait and see especially Dr. Salman.
Sounds good. Well, thank you guys so much. You have a great evening. It's late over there, so.
Thank you so much. Best of luck. Thank you.
Bye-bye.
So at the end, this is the barcodes for our next session. This week we have surgical tuberty this Friday. And this Saturday we have the surgical debate about thyroid papillary carcinoma with two great consultant surgeons. And we also have the ABC of research. Feel free to register from the barcodes or through the links in the chat. And looking forward to see you for the next session. And feel free to stay and register for the session. And if anyone finish, he can leave the session. Thank you.